Well, welcome back to the Medical Forum podcast with me, Dr. Joe Kostrich, GP and clinical editor of Medical Forum magazine. And today, very happy to be joined by Dr. Dan Fick. Dan, welcome to the program and thanks for coming in.
Thanks so much, Joe. Thanks for having us.
You're welcome. And look, before we get into talking things orthopaedic and imaging, which is going to be very fascinating as well, just for the listeners who may not be familiar with you, tell us a little bit about yourself and your journey to being an orthopaedic surgeon in Perth in 2026.
Oh, thanks, Joe. Working backwards from being a surgeon, we were lucky enough to grow up in Perth and UWA trained, and then went through the rigours of junior doctorship here in Western Australia, and really was attracted to that intersection of research and trauma and really fixing people with orthopaedic surgery. It's a very attractive specialty, very collegiate as well. A great group of people really making other people better, and it's very attractive as a specialty. So a natural magnetic pull for me.
Yeah, so you're drawn towards it, and you train, I assume, here and elsewhere also?
That's right, yeah. So UWA and going through the local system, we usually have 1 or 2 years of fellowship, so we go overseas. I happen to go to the UK, and we like to have that term practice on the POMs, getting up to speed with some of the finer details of being a consultant surgeon. So that's at the end of training.
Yeah. One of the areas that I know you're interested in that we want to talk about is integrated care and sort of, if you like, better connections and collaboration between, in this instance, GPs and an orthopaedic surgeon. So what do you feel are some of the more useful things that myself as a referrer can do, probably in the lead up, but also in providing information to you?
Yeah, I reckon that's one of the challenges for the ages, and it's probably been the challenge across medicine forever. There's all that siloed information between specialists and primary care providers. And I think the question works both ways. How do we help integrate our insights with your patient care? You get that longitudinal view, and we only get these little intersects from time to time with patients. So I think maybe the new tools with technology and communication, even things like emails or even a simple text message, we can often shorten that loop in communication for the patient. That patient left wondering, what's the next step? Where do I go next? If we can shorten some of those communication lags and communication gaps, I think patients will do a lot better. We can fine-tune and nudge them a little bit quicker in their journey.
There's something I often find patients are interested in is, how long before they even see you for the first time, what can I expect? How long might I be in for? Again, if that's going to be a surgical procedure, what might I have to do afterwards? All those very basic questions that eventually the person's grappling with when they're by themselves.
Yeah, and I think that story that the patients have of their own journey, we've both got a huge influence on how they frame that story for them. So from the GP and from the outset is helping them understand, well, what is this pathology? What is your journey going to look like? And when do we refer you on to specialist care? And how do we take you back from that specialist care? And framing that story, I think collaborative events like this, we can often have that common language and patients can perhaps better understand their own story. That for me has been the big shift with really communicating to the patients. It's not really about that bone-on-bone arthritis. It's about building your capacity. Maybe you're a little bit weak. Maybe we can help with that with some strength training prior.
And that's a really, I think, important point, because ultimately the person's probably less interested in what is being seen on an image and more, can they throw a ball or can they kick a footy with their kid or grandkid, or can they have less pain? So I think what you said there is really important, that it's about the person. The person has a joint, but it actually is about the person.
Yeah, I think building that capacity for that person, and we're all so unique. We're all fascinating creatures, really, at the end of the day. We're penguins and rhinoceroses and just different humans. Everyone comes at life differently.
Yeah.
And that, for me, is part of the treat and the challenge, is meeting each individual where they're at and helping them understand, well, what are the options available for me? How do I build that capacity? I just want to walk upstairs without my leg giving way, or I want to chase the grandkids, or get down on the floor with the toddler and get back up. Things like that. And then trying to frame that story for the patient in a way that's actually meaningful for them. Often it takes a long time for them to understand what's going on.
I mean, is that, and I'm just thinking aloud now, I mean, in terms of, say, referrals, I mean, typically it's going to focus on what the medical issue is, in this instance, the orthopaedic issue, please see, and this is the problems. As part of a referral letter, would a sentence or two about, well, this person is having problems getting up the stairs, or, something that puts a bit more context to their problem, is that helpful at your end?
Oh, big time, Joe. I think that's probably one of the biggest things that is lacking in some of the referrals now, is that nuance for the actual individual. The bone-on-bone or the moderate to severe osteoarthritis radiology lines. I mean, you and I have seen it. We have patients with horrible disease, terrible deformity, and they're actually not bad at all. They're still on the farm, they're still active, it's not a big deal. And then we have others who don't really have that much pathology seen on the x-ray, and they're crippled with it. So I think those little lines of functional limitations, they can't play with the grandkids. I think that's really valuable in helping cut through that signal-to-noise ratio in referrals.
Yeah, in terms of what is the person looking
for
what
are they after?
From being referred to a specialist, orthopaedic in this instance, that is going to make their life better. Now, I think you're right. I think we all get collectively a bit drawn into the medical side rather than the person side. So changing tack, and this is an area that I know nothing about, electro-optical system imaging. And in the lead up to talking to you today, I've just done a little bit of a search and find out A, what it stood for, and B, what its role is. The technology seems quite remarkable, and I'll confess, I've not seen one of these scans. I've never personally referred for one. Tell us a little bit about it.
Well, it's a technology that's sort of spun out of some of the physical or the research labs in Europe. In fact, it was a Polish-French Nobel laureate who kind of pioneered the technology behind this linear microdose X-ray that gives us a whole body functional X-ray in 2D and 3D. We actually get to see the whole person, not just the joint. It's quite rapid in acquisition, takes less than 2 minutes, and it's like an open telephone booth. It's not claustrophobic. You're not lying down in a scanner for half an hour, 45 minutes. Quite quick, and more importantly for us, it gives us a functional image. We see the whole person.
Right. So instead of typically somebody's lying down on the scanner, or they've got their arm on it, for example, so this person is in like I say, like a telephone booth. I don't see too many of those these days, actually. No. It's a bit off topic, and it is low dose, but functional, as in, like I say, they're standing or sitting. And from what I read, there's two-dimensional but also three-dimensional images.
That's right, because the images are acquired at right angles to each other simultaneously. We get both what we call an AP and a lateral, front to back and side to side images that are acquired quite quickly in these functional positions. So I typically like the load-bearing or standing X-rays because that's different to someone lying on a couch and having an X-ray of their knee. It doesn't perhaps reflect how their knee's behaving under load. And then that, again, frames the conversation with the patient. Here, look at your knee. When you're standing on it, look at that curvature. You look like a cowboy. We can measure that degrees. And even from an engineering perspective, the scan then changes the conversation to biomechanics. Here's your biomechanics. Look at your pelvic tilt. We can see the scoliosis in your back. And then that opens up a whole conversation around, well, what are the little things we can do to improve those things and optimize those biomechanics?
Well, that is sort of where I was starting to think and go, and you've touched on it. So somebody's come in, they've got, let's say, knee, problems, suspected knee, arthritis, and they're shown some some damage on plain X-rays. So in doing these type of X-rays, the ELS X-rays, what does that give you as information, potentially about surgery that is above and beyond? Obviously, the functionality is part of that, but how does that enhance or alter, maybe in some instances, what you might be planning or what the management may end up being?
Oh, great question, because one of the heuristics of surgery is if you're looking at a joint, make sure you look at the joint above and below. Often there's these patterns of referred pain, and sometimes we can be caught in a sort of surgeon's trap chasing a pathology with arthritis of the knee when in fact the main pain generator might actually be their hip.
It takes me back to med school days. They said, knee pain can be referred from the hip. Yeah.
And this is one of those technologies that ensures we don't miss that. It would be awful to take a patient through a treatment journey for knee arthritis and heaven forbid knee surgery when in fact the main issue is their hip. So it's one of the things that we've got in our armament now that can help protect the patient from those decisions that may not be in their best interest. It gets us back to the focus of what's the main mechanical pain generator. It gets us a better understanding.
So again, really basic question, but is this form of imaging, obviously it is for the whole body, but is this also applicable, say, for example, in shoulders or lumbar spines?
Yeah, it's very commonly used for scoliosis monitoring, and that's where the microdose radiation is actually quite attractive, especially in a younger population. You don't want to be exposing them across time to multiple X-rays or multiple CT scans. So the EOS scan is very good for surveillance of scoliosis. We use it for our hip and knee replacements, as I said, to understand the biomechanics and what perhaps we can change before they even get to surgery. We look at things like a foot wedge or a little heel wedge to accommodate a leg length discrepancy, and we can actually measure that on the EOS scan. We can say, oh, look, Joe, your left leg is 8 millimetres shorter than your right. Let's put a little wedge in there and help with that functional improvement.
I mean, I'm obviously having sort of images in my mind of things in the movies and sort of like a skeleton that's sort of spinning and turning around. How do patients find these images when they get to actually see them?
Well, I think like everything, it's how we interpret the scans, and often it can be a bit confronting if you just see yourself in the mirror and have a look at the whole body scan, but. Really, it's about the interpretation of the scan for the individual, and that's where we're lucky with surgery. We get to look at that intersection of what is the pathology and then what is the patient or the person in front of us. So for a patient, it can actually be quite validating where they can actually see themselves. They can actually see the pathology and what it means for them and the knock-on effect for their skeleton. They can finally understand, that's why my back is sore because my hip is stiff. I understand now.
Do you find that there are sort of two groups of people, those are really fascinated and want to look into every sort of, what's this, what's that, and other people, I don't want to see it, I don't want to know?
For sure, that analytical subset that wants to know everything in every degree, and we have terrific conversations with them because it's nice to be able to go into detail around it. Most people just want to be seen, to be understood, and have their sort of problems put in a way that's attainable for them to understand. I think that's where the EOS has been great for us to actually tell the patient's story in a manner that's sticky. They remember things when they see it.
Do you do, and again, 101 question, pre and post? So if somebody's had joint replacement surgery, will you do post-op EOS at some point to see how it's gone?
Yeah, especially if we're doing big deformity corrections, if they've had more complex surgery to change the length of the leg deliberately to correct some of these issues. The post-op EOS is really a great ground truthing for them for their recovery chapter. We share that then with the physios, the podiatrists, as we say, and just set them up for the understanding of their new body.
That's when you mentioned their physio and podiatrist. We've had people from different specialties on the podcast, and one thing that I've noticed is almost everything now, there's multidisciplinary input. So as part of the workup towards surgery, do you get a team involved with, it's like sometimes a nurse specialist who liaises with the patient and people like physios and podiatrists? Is orthopaedics going down that path as well?
Very much so, and I think that's actually where most of the improvement in our care factor has come from, is that collaboration before the surgery. And we're talking long before the surgery, sometimes years before surgery, Joe, helping people build their capacity and understand that it's not just about the bone-on-bone arthritis, but it's how we build up the strength to cope with that and to be stable, to be able to do the stairs, get down with the grandchildren.
So with that in mind, I think there'd be a lot of GPs, and I'll probably put my hand up to be in that boat, that often will say to people, look, you probably don't necessarily need to go and see an orthopaedic surgeon until we're really thinking about surgery. But what you said then makes me think, well, is there a case for sending people along a little bit earlier? Okay, I don't think, look, that's for you and the surgeon to discuss, but no, I don't think you're right at the point of surgery, but maybe it's a good time to start the ball rolling so you understand more about it.
I think for a lot of patients, that's exactly what they feel. They want a trajectory, a pathway to understand this. And sometimes coming from the pointy end, seeing the surgeon, being reassured, it doesn't matter that it's bone on bone. It's all about function and capacity. Getting that reassurance from a surgeon often can help them engage and be more compliant with physio. A lot of time, if we bark an instruction, a patient, go to physio, get strong, they don't stick with it. And we've got to actually give them the why of why that's important for them.
I think, and the analogy I very often use with patients is the footballers. So look, you might think surgery is it, that's the end, but in actual fact, it's the beginning. Like if you see footballers, they've had, it's just a slightly different issue, an ACL repair. They don't get back on the field for a year. So it's very much after you come out of the operating theatre, that's not the end, that's the start. Do you find people also have to be sort of a little bit disavowed that once the surgery's done, mission accomplished?
For sure. And that expectation setting, I think the sooner we start setting expectations for what does this journey look like for you, the better patients then can cope with that journey. Because a lot of uncertainty, a lot of unknowns in your recovery, people just want to know and be reassured, actually, this is normal. It's going to take time. Your body needs time to heal. Give yourself 12 to 18 months. It's not a race. And along the way, there's going to be different chapters of rebuilding your capacity so you have the strength to cope with whatever you want to get back to.
Sort of coming back to the EOS scanning, you said it had been in WA for 7 or 8 years or so. Is it widely available?
Yeah, there's a number of practices now that have the EOS scan. It's not everywhere, I would say, but it's something that's so quick and easily accessible. It's basically X-ray technology. A lot of it can be bulk billed now.
Okay.
So the access for patients is improving. There's even some down in the southwest now, the regional centres are starting to see that it's very valuable for our patients in the community.
Ultrasounds typically are described as sort of operator dependent. We're chatting with Tom Shannon. He was talking about MRIs, and his view was they were very interpretative dependent. The EOS, is there what degree of sort of operator dependency or interpretative dependency factors into these?
Well, for me, it was one of the attractions of orthopaedics because there is this engineering principles for the human skeleton. We get a chance to measure angles. We look at limb lengths and we can look at in degrees and millimetres. So that blueprint for a skeleton often is quite absolute. It's quite definitive. Your leg is 8 millimetres longer. There it is. So there's very little interpretation on that side of things. The interpretation is, well, what does that mean for me? What does it mean that one leg is 8 mils longer?
Yeah, which comes back to what you're saying about functionality. Is there much or any case for a referrer to have done an EOS image in advance, or is that's really your department?
Well, I think perhaps at the moment it's easier for me to help interpret the image, and I think that's probably the big challenge is if I order this test, how do I interpret the result? And I think that's probably going to wash across the medical community across time as we learn more about these new technologies. It's not just EOS, there's newer and newer things that come all the time, and understanding how we bolt that into primary care and the patient's journey. That's something, for instance, we're not taught EOS in med school at the moment. We're not taught about how to interpret a full body scan for the patient. So there's a lot of making it up as we go along in that sense with medical education.
AI seems to be coming into everything these days. Role of AI in I suppose both this EOS imaging, but also where do you see AI coming in and assisting with maybe planning surgery and factoring in with robotic type surgery?
Yeah, I think helping with that personalisation and, in algorithmic medicine and evidence-based medicine, there's a lot of if this, then that. That sometimes maybe doesn't capture the individual nuance for a patient. And maybe I think the new AI tools will be able to help just change that focus a little bit and make it a bit more personal.
I think that's a really good point that you made there, Dan, because there is a tension between guidelines and protocols that assume everybody's the same and helping the individual person who may not be the quintessential protocol person. I think there's a real tension there at times.
And these tools, I think, also shift the balance of power to empowering patients to better understand their pathology. So a lot of patients now are taking the tests that you and I perform and they'll put it into the AI and say, what does this mean for me?
Yeah.
And then you and I, we have to help them with that output.
It's a little bit, I think, with AI coming in, is a little bit like the early days of Google when everybody went on to Dr. Google. And yes, it's told me this and the other. And then I found over time that people became less trusting of Google. Initially it was, Google said this, it must be right. And over some years, I found the opposite. People would come in and say, well, look, I went on to Google, but I thought I'd better come and see you because I'm not quite sure. And I wonder if AI might have a similar sort of journey. At the moment, everybody is just going to accept what it says.
Yeah, that trust, I think, is so important. And as clinicians, we safeguard that. And really is our privilege and our honour looking after patients. And I think patients pick up on that. They understand that we're there for their best interest. So balancing that insight from an AI with the trust from a real-life doctor that's going to help me interpret that.
Yeah.
I think, as you say, that tension now is, I think that's where we're at in 2026.
Yeah. And then looking at, I suppose, the post-operative period, pain management has obviously advanced a lot over the years, but also had its bumps, particularly with opioids. Where do you think we've made some positive changes in terms of post-op care and particularly getting people up and about and helping them with their pain?
I reckon that's honestly been one of the biggest changes in orthopaedic surgery is the parallel advancement in anaesthesia, the gentleness, Joe. It's a lot simpler and a lot gentler now, the modern anaesthesia. These regional techniques, let's just numb that leg for an hour or two, do the surgery, and then transition onto some much gentler non-opioid pain-relieving strategies, as opposed to the old days, let's bomb you out, let's give you a general anaesthetic for a couple of hours and you'll be a zombie. A lot of older people have that concern that, Auntie Doris was never quite the same after that anaesthesia. It scrambled the eggs upstairs. So a lot of our modern surgery, in fact, all of our joint replacements now are done under regional anaesthesia. There's no major general anaesthetic that's given now for the modern hip or knee replacement.
I'm just doing a bit of a double take there, and obviously it's not my genre. You said pretty much all joint replacement is now done with
That's right.
either regional and or some light general anaesthetic.
So virtually all our patients now have a single spinal injection. That numbs you from the waist down for 2 or 3 hours. There's been advancements in the level of that block. Sometimes, in the old days, we used to give you a very heavy type of local anaesthetic that would last for most of the day. People lost control of their bladder and we had to catheterize them. Nowadays, much shorter acting agents. We don't have to use urinary catheters. The anaesthesia only lasts for an hour or two. You're wiggling your toes pretty quickly, and that avoids the need to intubate a patient. So patients do their own breathing, often just with an oxygen mask and a very light sedation. Have a gentle dream. Off you go, wake up in an hour and it's all done.
That really is quite amazing. I do remember being an intern at the old Shenton Park Hospital, apartments and the lot now, in the 80s, and joint replacements were still relatively new in those days. There's nothing gentle about it, as I recall. And people are in hospital for close to 2 weeks after a hip or a knee replacement. Again, obviously each person is different, but how sort of quickly can you get people home after they've had joint replacement surgery now?
There's a move globally towards that shorter stay surgery. Sometimes the drivers for that are a little aggressive. For instance, in America, a lot of joint replacements, it's all same-day surgery.
Same day.
You go home the same day, Joe. It's quite amazing to see. But that, to me, shifts the burden of care to, well, who's going to help you at home? And a lot of times people don't quite have the setup at home to enable them to get through that first 24, 48 hours. So we adopt a hybrid model now where we'll get you up on the same day. Within a couple of hours, you're walking. But stay a night. Couple of hours, yeah. But stay a night or two and get you home. Once you're safe going up and downstairs and you've got your confidence, got your mojo back a little bit. So most people stay 1 or 2 nights.
Yeah, which, again, compared to, 40 years ago was towards 2 weeks. Which leads to the next point. What, at the other end, somebody has gone home, what potential problems might I see if they sort of come unstuck on a Friday afternoon?
Yeah, so the big issue for us now with the simplification of surgery and anaesthesia, a lot of our patients are actually feeling almost too well. So a lot of times we actually have to warn them, slow down
a bit.
Slow down. And this has actually been quite a big shift over the last few years from a rah-rah aggressive physio, we'll get you going approach to actually, hang on a minute, I need you on the couch with some ice on your knee and just watch Netflix for a week or 2. Jump off the hamster wheel of life and slow down. Give your body time to heal.
So with that said, is there and again, everybody is different, but is there an indicative time when physio does start post-op?
Well, I think the correct answer to that, it actually starts pre-op. So a lot of time preparing patients, building their capacity and strength, that really sets them up for a great recovery. And that's been quite a shift the last few years to not rushing into surgery, building that capacity beforehand. If you put the work in beforehand, like anything, you're going to reap the rewards afterwards. So if patients have a great pre-op or prehab, they get their strength up, they have their surgery. It's usually 2 quiet weeks just to let everything settle down. By that stage, most people are off the crutches. Most wounds have healed. We use dissolving stitches now, so no stitches have to come out. And then from 2 weeks onwards, we say, right, plug back in with that physio and let's get you back to where you want to be.
And I imagine if that's all mapped out some weeks, maybe even months before surgery, then people have got, it's like they've got a journey, like we were talking before about UBDs, the old-fashioned things, but I've got a bit of a map as to what's going to happen and a bit of an indicative timeline as to when. Does that also, we touched before about the team involvement, is that also getting team involvement from the get-go? Yeah,
and I think that's where maybe these new technologies help us collaborate a little bit better with the team. So a good example is we've started push messaging, text messages, daily text messages to patients to just let them know, look, today's day 3, you might actually feel a bit blue today. Go easy on yourself. Check in with a loved one and take it easy today. And that little push message validates them, gives them permission. Oh, yeah, I actually do feel a bit blue. Oh, that's normal. Oh, that's okay. So helping patients benchmark in that journey, they don't know what they're meant to feel like after an operation, but we can help guide them and improving how we guide them. I think that's been the challenge for our age.
Yeah, because I think historically people came out of hospital, all good, see a GP. If you've got a problem, come and see me in 6 weeks. Yeah. So that's a massive change in approach.
Yeah, and I think just looking at all the issues that can occur in that post-op period, a finer detailed management plan set up beforehand often helps us navigate through that, the first post-op period.
Yeah, and what might be a couple of the issues that might bounce in to see me, they think, I don't want to go back to the surgeon, but I've got a problem. What might some of the commoner ones potentially be?
Look, for us, I think sleep is probably the big ones. These problems that we're talking about, Joe, the hip and knee arthritis, the major joint arthritis, people have issues not sleeping for years. Then they have surgery. They are perhaps given some of the analgesics that maybe upset their sleep patterns a bit.
Right.
And really for the first 2 or 3 months, that sleep disturbance is quite challenging for a lot of patients, especially if you're young, you're dynamic, you just need to rest. You can't switch off. You're watching the clock at 1, 2 o'clock in the morning. You just want to sleep. And that's a problem that can be managed better if we get it earlier.
Dan, that's been really interesting. And it does, I'm showing my age when I think about my term as an orthopaedic intern, and really what you've described is just unrecognisable in terms of the approach. As we sort of wrap up, I think we said at the start about collaboration, and I would hope over the next so many years that GPs maybe get more involved in that team. At the moment, I think we still largely sit outside it, and that's structural, so it's not anybody's fault. But I think the more collaboration there can be going forward will be a good thing. Have you got some key take-home messages for the listeners today?
Well, I think for me as a surgeon, not letting scans drive the decision for surgery for a patient, and it's more about building a patient's capacity, helping them cope with what they have. Often if we have some insights from some of these newer scans or from a surgical consult, we can control that patient's preparation long before they ever need any surgery, helping them live the life they want to live with some of these newer insights. Some patients do much, much better if we don't rush into surgery and we just all work together to help them understand, the suite of tools that are available to them.
Excellent. Dan Fick, thanks for your time and coming on the Medical Forum podcast today.
Much appreciated. Thanks, Joe.